Welcome to week 9. We're discussing the case of Clayton, presented by Group 4, Julie, Mackenzie, Britney, Alyssa, and Eureka. Clayton's case summary. Clayton, a 61-year-old man, quit injection drugs long ago but developed alcohol dependence. He's been sober for 18 months after treatment. He has liver disease but refuses a transplant. Clayton attends AA meetings regularly, is a part of a recovery group, and sees a counselor occasionally. He lives alone, has limited contact with his adult children, and retired 3 years ago. Recently, he had suicidal thoughts due to pain and a sense of hopelessness. And last week, he handled his gun, prompting his AA sponsor to urge him to see his counselor. Below are some transcripts from Clayton's therapy session that would raise some concerns and encourage the therapist to do further assessment. Based on the assessment, the therapist is required to report the suicidal ideation if intent to harm was present. What happens if the bad pain comes for several hours, sometimes 4 hours or so, and it makes it hard for me to do anything? It just beats me down. Clayton uses the words beats me down to describe how the pain affects him. Beats me down implies that Clayton may be depressed. It can mean that he's tired, worn down, hopeless, and feels defeated. The therapist asks Clayton, when the pain has gone up to an 8 to 10 level, those are the times when you feel like you're sinking and feeling down. Clayton, tell me more about what those terms mean to you. Sinking can mean that he's overwhelmed, overtaken by emotion, and often can be linked to anxiety. Feeling down means that he's going through a difficult time, feeling sad, hopeless, empty, and depressed. Tell me more about what those terms mean to you. Here, the counselor is wanting Clayton to say it in his own words what those terms mean. Based on how he would describe them, it can give the counselor more information on how serious the situation is and if there is any suicidal ideation behind those words. Clayton says, I don't want to be a burden to anyone, and I don't want to slip again. When he says he does not want to be a burden to anyone, this implies that he's afraid to ask others for help. This can bring upon feelings of loneliness, emptiness, and sadness. I don't want to slip again can mean many things in Clayton's situation, from his depression, anxiety, and addiction. In this case, it sounds like his addiction to alcohol is what he's afraid of slipping back into. He knows that his dependence on alcohol is harmful, but he uses it to numb the pain that he's experiencing. With a combination of depression and alcohol abuse, Clayton is at an extremely high risk for suicide. Although Clayton has not fully expressed suicide ideation, the terms, the feelings that he has described, and the simultaneously having possession of a gun are all commonly associated with suicide. And therefore, the therapist should continue asking more assessment questions that we will discuss in our presentation.
Hi everyone, my name is Brittany and I will be talking about the assessment question. So when we assess Clayton's situation, we need to gather more information about his physical, emotional, and social well-being. Some questions are, you mentioned thoughts of killing yourself. Can you describe how often these starts occur and if you developed any specific plan? You decided not to consider a liver transplant. Can you share more about what led to that decision? Have you explored all your medical options with the doctor? You mentioned occasional contact with your children. Would you like to have more regular communication with them? How do they support you? You said you examined your gun last week. Do you still have access to it? Have you made any specific plans regarding it? How do you feel about the changes you experienced since retiring and becoming sober? Has it been difficult to adjust? And how do you feel about the support you're receiving from AA and your recovery group? Is there anything more you think you may need? So the purpose of these questions is asking these questions allows a therapist to build a full picture of Clayton's physical, emotional, and social well-being for treatment planning. It would also help us identify any immediate risks like suicidation, relapse, while also addressing longer-term issues like social isolation and pain management. And asking questions about Clayton's emotional and social support helps us evaluate if he has resources to positively cope or if additional measures are needed. And some of the assessment questions, some of the connections to the book are maintaining professional boundaries and respecting autonomy. So the therapist needs to ensure that Clayton has the social support he needs, which can significantly impact his mental health and recovery, but also respecting Clayton's autonomy and deciding whether or not to pursue more frequent contact with his children is essential, as that maintains professional boundaries and respects autonomy and self-determination. So the therapist has to explore how these life changes since becoming sober could be affecting Clayton's mental health and whether additional support is needed. And self-determination and authenticity are central concepts in ensuring a therapeutic relationship that empowers Clayton to take control of his life.
I am Mackenzie, and I'll be talking about the ethical and legal obligations of the therapist in the case of Clayton. Our first ethical and legal obligation is the duty to protect. The therapist has an ethical and legal duty to protect Clayton in the case that he's having suicidal ideations. After further assessing the threat with follow-up questions and a risk analysis, the therapist would need to report the suicidal ideation if intent to harm was present. Counselors can be accused of malpractice for neglecting to take action to prevent harm when a client is likely to take the step of suicide. Yet they are also liable if they overreact by taking actions that violate a client's privacy when there is not a justifiable basis for doing so. This makes this situation complicated because we don't want to report something before we have the proper amount of information. So that's why the follow-up questions and risk analysis are so important. Suicide risk assessment requires clinicians to identify client risk factors, warning signs, and protective factors that can work to mitigate the risk. In Clayton's case, examining the weapon and some of the language he uses in his transcripts would cause us to have some concern regarding his risk for suicide. The therapist and client collaborate in developing a personalized safety plan, which is designed to assist the client in weathering the storm of suicidal thoughts and impulses. So, moving forward, we would make a plan to try to prevent any self harm. Our next ethical and legal obligation is disclosing the limits of confidentiality. The therapist must be upfront with clients about the limits of confidentiality. These limits include when a client intends to harm another person or themselves. So, although we normally tell our clients anything that we talk about in therapy is confidential, in the case where self harm, like in this situation, could be an issue, we would have to report it to the proper authorities, and that should be disclosed at the very beginning with our client. The American Association for Marriage and Family Therapy states that marriage and family therapists disclose to clients and other interested parties at the outset of services the nature of confidentiality and possible limitations of the client's right to confidentiality. Therapists review with clients the circumstances where confidential information may be requested and where disclosure of confidential information may be legally required. Circumstances may necessitate repeated disclosures. California Business and Professions Code 4980.36 D24. State law requires mental health professionals receive training in suicide assessment and intervention so that such clients can be properly assessed and treated, ensuring that they do not ultimately hurt themselves. This is where the follow-up questions and the risk analysis become extremely important. Code 81, California Appendix 3D 6141978. A therapist does have a responsibility to take reasonable steps to prevent threatened suicide. Those steps may be the risk analysis as well as notifying authorities. As part of the informed consent process, therapists must inform clients that they have an ethical and legal obligation to break confidentiality when they have good reason to suspect suicidal behavior. Based on what we know so far, it's definitely concerning regarding some of Clayton's behavior and language, but we would want to follow up more so that we don't break the trust unless there's an actual threat of suicide.
Hello, my name is Alyssa. I will be completing the steps in ethical decision making and intervening with a suicidal client. After reading the basics of California law for LMFTs, LPCCs, and LSWs, I learned some more information about how to intervene with a suicidal client. First, it is essential to create and complete a suicide assessment. The assessment is able to give the therapist more information regarding the client and their suicidal intent. For example, do they have a suicidal plan? Do they have the means and what they need to complete that plan? And do they have a specific time frame? These suicide assessments are very essential in order for the therapist to gain more information about the client and what is exactly going on. After completing a suicide assessment, it is important to complete a safety plan. However, safety plans are most often completed and used for clients that are low suicidal risk. A safety plan is a written agreement made between the therapist and the client, which addresses some steps the client will take before they do anything harmful to themselves. For example, if the client begins to think about suicide, they have a list of things they can do before they do anything to harm themselves. So, example, first on the safety plan would be if they begin feeling suicidal or they think about suicide, to make sure they can either call a friend, call a family member. If no one answers, then they can call. The next thing on their safety plan will be to call their therapist's office and see if they can come in, if there's an available appointment. And if that does not work or they're busy and don't have enough time available, then the next thing on their safety plan would be go to a medical clinic or the emergency room or some type of situation like that. So the safety plan gives options of things that the client can do before they do anything to harm themselves. Another thing would be increased frequency of contact. So typically, therapists may see their clients once a week, once every other week, maybe sometimes less, depending on how busy the therapist and the client are. So increasing that frequency of contact, whether it's a phone call or more office visits, can really help the therapist monitor the client and see how they're doing, and if their symptoms are worsening. And this is essential to during this time to be able to hear from them more and get a better idea of how they are doing by talking to them more frequently. Also, care of a loved one or even being surrounded by others can be an option if the therapist feels concerns. So just having that support around you and being near others, loved ones, friends, family members, anything like that. And then if the client poses imminent danger to themselves, then at that point, they would have to go to a hospitalization. So they would have the option to go voluntarily or due to the client posing imminent danger to themselves. If they do not want to go voluntarily, then it would have to be involuntarily.
Hi, my name is Eureka Williams, and it steps in ethical decision-making, intervening with Clayton. In regards to in a mandated reporting situation like Clayton's, ethical decision-making is really crucial to ensure the safety and well-being of all individuals involved, including Clayton and the therapists themselves. The process begins with really assessing the situation and gathering comprehensive information about Clayton's mental state. Following this, it's evaluating the level of suicide risk which helps determine the urgency of the interventions needed. It is essential to consult relevant ethical guidelines and legal obligations concerning mandated reporting specific to the jurisdiction, indicating wherever you are living, you should be following those applicable laws. Engaging in open dialogue with Clayton can provide insight into his feelings and thoughts, and then fostering a supportive environment if he is assessed to be significant risk, involving appropriate professionals as well, such as emergency services, 911, if it needs to get to that level. Our intervention specialists may be necessary to address his immediate needs effectively. With the continuation of slide 2, if Clayton is deemed to be imminent risk, what we want to do is proceed with mandated reporting to ensure his safety. Next, we want to collaborate with him to develop a safety plan, which is crucial. And this should include coping strategies and then, of course, emergency contacts as well, with Clayton and monitoring his progress with help providing ongoing support. Additionally, throughout the entire process, we want to ensure that we document decisions, document actions, document times where he's in therapy sessions just as well. This will help effectively navigate the complexity of his situation, really while providing Clayton's safety and well-being.